The Shift is brought to you by SE Healthcare. Welcome to The Shift. I'm Dr. Andrea Coyle. Welcome, Shifties, back to the next episode of The Shift. Today is a first. It is a second date for myself and Dr. Jeanne Venella. As you all recall, Dr. Venella was here. She was probably here about 6 or 7 months ago. We talked about workplace violence, and she promised to come back. And true to her word, Jeanne is back. Jeanne, welcome back to the podcast.
Well, thank you. Thank you very much. It's a pleasure to be back. And I like second shift. I worked second shift almost my whole career in the emergency department, back when it was 3 to 11 before it morphed into many, many other shifts. But it's a pleasure to be back. And sadly, since we last met, there hasn't been much movement in the space of staff safety. And as you and I always talk about, the Maslow's hierarchy, if your staff aren't safe, they're not feeling secure, then how in the world can they be expected to deliver excellent patient care? So I'm glad to be back talking with you, bringing some light to bringing some real focus and light to this issue of workplace violence in healthcare.
And I like that you're very candid and honest. We're going to have a very candid, courageous discussion today on the podcast. So remind the Shifties, when you were last with us, there was a day on the Hill. Mm-hmm. Any conversation that would be really important for Shifties and others to learn about? What did you learn from that day on the Hill?
So I learned that day on the Hill, which was really a dynamic experience for me. Really, it was a pinnacle moment. But what I did learn, while individual legislators, both in the House of Representatives and Senate, from both parties, believe with all their heart that nurse assault should be federal legislation, just like for airline staff, mm-hmm. that our government, without getting political, is so distracted right now that no one can get this bill passed. And so it remains blocked. It remains tied to a lot of other pieces of legislation. And therefore, I would say we're probably no better than we were at 2024 day on the Hill than what I saw at 2025. So while everybody will speak to you candidly, oh, yes, my mother was a nurse and this is terrible and nurses shouldn't be hurt at work, it's just tied up in kind of a confused legislative cycle.
Yeah. And, I always say nothing perpetuates disengagement like confusion. And when we have all this confusion about keeping us, healthcare providers, nurses safe, that contributes to the burnout. That contributes to people leaving our profession.
Oh, absolutely. I mean, burnout is a growing crisis. You speak on it every day. But the three main contributing factors, or what's so popular in healthcare right now, is the buzzword cognitive overload, right? Mm-hmm. Emotional strain, and workplace violence. And since we last met, we always like to leverage and talk about statistics. Both of us have our doctorates in nursing. And, there's a recent article in June of 2023, Nurse Leader Online, alarming rise in nurse assaults. And I used to say nurses are 4 times more likely to be injured going to work than a police officer or a sheriff. And in fact, now in 2025, it's now 5 times more likely to be injured at work. And so I always say, you see a police officer, even in my little local town, pulling over a car for maybe a traffic violation. It gives you pause. You think about what procedures they're following as they approach the vehicle. I watch it. When I put my stethoscope around my neck to do a shift in the ED, nobody thinks that action is as dangerous as pulling over a car for a traffic violation. So it's so serious. And the state of healthcare, and again, back to the confusion and the Medicaid cuts, there is only a finite amount of money that hospitals can spend, and how they're spending it is up to their each individual institution. But I see less money being spent right now for the technology and the training that can help with workplace violence, in addition to, the burnout, stress relief solutions. So it's confusing to staff.
I agree with that. It's very confusing. It's almost like confusion fatigue. And I just made that up on the fly because we have so many competing priorities and what's important. But if you think about Maslow's hierarchy, that's what we need to address: food, water,
Food,
air,
air, and water
safety.
safety. Right. You can't build on that. And, since we're on second shift, right? Our second date, do you know that like 75% of registered nurses on second and third shift have less than 2 years experience? So they don't have that like fact checking gut instinct of this is going to escalate. If I do this, this may calm. This is how I stay safe. And when you go back to Maslow and you don't have this like kind of built knowledge, lived knowledge, you how can you look at your watch for time of antibiotics if you have one foot out the door trying to keep your back to the door being safe, right? So it's a conflict. And it goes back to that cognitive overload. You go back to the med room, you think to yourself, oh my gosh, I didn't check the time. I was so worried about my safety. And now you've got to make an incident report because you've got uncharted incidences that you are supposed to be keeping track of. And so, that contributes to decreasing quality of care.
Well said. And I'm just curious. I was an ICU nurse. I floated to the ED. You spent a lot of your career in the ED. And this isn't really about the ED, but my assumption is, and you can fact check me, is most violence on nurses happens in the ED. That's a point of entry to the hospital. So what can we do? Does it start in nursing school? Do we start talking about these escalation strategies in nursing school? Are we doing that? Like, what's ENA's position on this? Can you enlighten me? Because
So the threats there are still, the RNs are still the highest group of targeted by the assailants. Physical assault is the most common. Behavioral health units do rank number one, followed very closely by emergency departments. And we'll remember after COVID that pediatric organizations finally came out and said, due to the high stress, the nature of waiting, the volatility of a sick child, that the pediatric organizations also, see this a lot. So what's the answer? That's the $1 million question, right? Training, education, and lived experience are really how you start to understand, what you're seeing translates into the patient may take action, right? So I've talked to a lot of nursing schools. One of the things also happening at the hospital level is that they're reducing hours of hands-on education for behavioral responses, and really just now having those kind of super elite behavioral response teams. Rather than, and we went through this with millions of other opportunities, right? So you only train the trainer, and then you have a kind of a super user group on the unit. And if some X procedure has to happen, instead of training or educating 30 nurses, you've got this, super user on each shift. So now we have that in behavioral response teams, which are really very good to bring in additional people and not always just security to, manhandle, right, the assailant. You want to be calm and not further escalate, but you have less world-lived training. So back to your question, yes, it should be in the sim labs at all of our organizations. I advocate for even like when you're scripting, when you're reading your script in the sim lab, you call 911. You do this, it's really routine that you start to understand, like the team steps and in trauma. You say, yes, Andrea, you have the head of the bed. Jeannie, you have the documenting role. You call security. You press your duress badge. if it's, all the things that you script so that when you're in that situation, some of that practice comes back to you, as your lived experience.
Yes. And, I recall this was years ago. I was a new nurse, and a nurse supervisor was rounding on the night shift, and she was kicked in the face, and it was permanently disfigured. She required multiple surgeries. And not only is there violence, but what are we doing to help the people that have been victims of violence? That's a whole nother.
That's a whole nother hour we could talk. Now think about, I don't know if you've ever been a unit manager. I have. That job is just so thankless, right? It's so hard. You're doing work that goes up, doing work that goes down for your staff. You're in the middle and no one's doing any work for you, right? I always say, like, who's helping us in servant leadership as the nurse manager? But what he was talking about is the culture on the unit is so important. And burnout really is, it's a work related syndrome. It has nothing to do with your personal characteristics. But if you come to work and you're assaulted and your peers are mocking you because you're not tough enough to take it, and the culture isn't one on your unit where this is not okay, then you really feel like you're personally not accomplishing anything. And really it's the work unit that's not accomplishing. It's not personal. And, honestly, I always say to people when they don't feel that way that you need to find another unit where you can feel supported, right? So it's so hard because the nurse manager creates the tempo and the temperament of each unit. And when you tolerate any abuse, whether it's from staff, from patients, from visitors, then you're setting yourself up. It's got to be a no tolerance. It's got to be a no wake zone, like they say out on the bay. No wake, no rough waves. It's got to be smooth, calm sailing, and there has to be a respect towards that. And when you speak up against it, you shouldn't be looked upon as not being able to handle it, because that's not fair at all. It's not. It's a work related thing. It's not a personal thing.
I had an aha moment many years ago when a friend of mine worked on a surgical oncology unit, and a patient picked up a very heavy piece of equipment in the room and threw it at a nurse. Luckily, it didn't hit the nurse, but if it would have hit the nurse, she would have required stitches and surgery. I mean, it was ridiculous. And this is where I think we still continue to need education and awareness. The nurse manager said, instead of, "Are you okay? Let's talk about this." The nurse manager said, "What did you do to provoke that patient?"
That's absolutely the worst response you could ever do. Absolutely. I mean, you don't do anything besides what you're directed to do to provoke, right? You're going at it with empathy and kindness, and certainly patients are raising their voice and cursing and spitting and not being tolerant, but we can't match that word for word. We have to come at it with a level of empathy. Yes, waiting is terrible. Yes, you're waiting for bad results, but that still doesn't give you the right to spit at me or bite me or hurt me. And the manager needs to come back and say, this is a unit where we respect all people, and that you're not respecting my staff. And so when you act like this, these are, I don't want to say penalties, but these are the results of these are the consequences of your action. Now you're not going to be able to have X or not be able to have Y, and you can't roam free, in the corridors and aggravate more of our staff. So the manager sets the tone for the unit. And, Jeff Dr. Doucette was saying, like, how thankless the nurse manager job is, but yet how vital it is down at the cellular level of keeping that unit from not having any tolerance for workplace violence, verbal assault, physical, and the like.
And I agree with that. It is critical. The nurse manager plays such a paramount role in healthcare and it's a difficult role. No one will deny it's a very difficult role. They have to straddle leadership And sometimes they're straddling staffing because sometimes they still have to staff.
Mm-hmm.
And, they're stuck in this really difficult place. And, I really believe that it's, if you permit it, you promote it.
Oh, my favorite.
And exactly. And in that role, you have to have no tolerance for workplace violence. You have to have no tolerance for bullying. You have to have no tolerance for gossiping. I had a really great nurse manager friend years ago, and she had an amazing, amazing culture on her unit, because if somebody started gossiping, they were hurtful, not helpful, they had an immediate, courageous conversation. And if they didn't fit into the culture, they didn't last too long on the unit.
Mm-hmm.
And
And what's important to that, Andrea, is not passing along a bad team member to another nurse leader without being truthful and say he or she just didn't blend in our culture here, right? And then it's up to the transferring manager to understand that. But, kind of moving a bad penny around doesn't really help for
exactly.
organization or culture.
100%. So if we could leave the shifties with a couple words of wisdom today as it relates to workplace violence. One thing I heard you say is that we're really not moving the needle as quickly as we need to. And so how can we do that? Can we continue to have these discussions? What would you suggest?
Well, my latest soapbox that I'm thinking about to myself is and I'm using a parallel that's old, right? But if you remember back in the early 90s when the pulse ox became the fifth vital sign,
Yep.
right? Do you remember that literature came up through technology, right? Like you wouldn't put somebody with shortness of breath into the waiting room in 2025 without having checked a room air pulse ox, right? So my new thing is every staff member deserves a wearable safety badge. Like I think it should be part of your uniform. That's my new soapbox. Now, that's certainly harder than getting pulse oxes for patients that are waiting. But I believe it should be part of our equipment. When my daughter goes to work, puts her stethoscope on at night, I believe that she should have her own personal duress button. And so that's kind of where I'm coming from it should be part of your equipment when you put on your equipment to start your shift. I also think we need to impact, especially the younger staff, that it's not personal failure. It's a systemic issue. And, oftentimes lived experiences just don't happen in those 2 years in nursing school in preparation. And you have to witness people who handle situations the way you would want to handle them. Also witness people who handle situations that you might not think is what is best for you. And you have to take that lived experience and then start to create your own scripts and your own responses. But it does take time, but not take it as, oh my gosh, I go home every night. I think I missed items of care. I don't think I did the best for my patients. I'm also spending 4 hours charting at the end of the shift. All those things that add to the cognitive overload, that add to the emotional strain, and then you've got burnout. So it's small steps, but it's valuing each other as teammates with courageous conversations, with honesty, and reporting. So let's end on that. If you don't report workplace violence, then your leader has no clue into what you're experiencing on your shift. And a lot of times you hear people say, well, he just raised his voice. He just yelled. She just yelled. They just did this. Just can't be tolerated. Because the next time say, I always use this example. I know I'm running on, but I've got a lot of experience and I kept this patient calm all night. Well, how did I do it? Well, I might have some strategies. I might have some tips and tricks. And then I hand off in the morning to someone new on orientation who doesn't have those tips and tricks.
Mhm.
And they go in, and then that patient implodes. It's like the lid blows off the top of the crock pot. You have to be honest and say, this patient required so much energy last night to keep him or her calm, and not set up that new to practice person without having had that conversation. So open, honest communication, recognizing what we do is not easy, and that we have to help with those lived experiences and teach what a model we want the staff to be able to respond to in those difficult situations.
You hit the nail on the head. And that's what I was going to offer to the shifties. It's about open, transparent, candid communication. And it's the same thing, we promised the shifties you'd come back. And what's interesting here at SC Healthcare, because we're laser focused on clinician burnout, what we have heard and what I hear across the board, across the country, across the globe, actually, with leaders that I'm speaking with, workplace violence is continuing to be one of the top stressors. I mean, as you know, people have asked for more content at SC Healthcare. You're helping us you've developed some of the content for us. Mm-hmm. So if you're an ANA member, you have a member benefit, check out Dr. Venella. She talks about workplace violence. It's about creating this culture, and language and communication is part of a culture. We have to create a culture where people say, no, this just isn't good enough. No, we are not going to tolerate workplace violence. No, we're not going to tolerate not setting boundaries and burning out. It's all a culture that we have to create. And that is hard work. And I think a lot of it starts with us having these discussions, awareness. I love what you said. I always think about AM huddles, Jeannie. Mm-hmm. When you start a shift at 7 a.m. and you have your day shifters and your night shifters coming on, let's talk a little bit about workplace violence in the moment, in the care delivery environment. Hey, did you remember that if your patient demonstrates X, Y, and Z, they might be escalating? Mm-hmm. Hey, did you notice that the workload's high today? Let's talk about the workload and how we can help each other so nobody gets stressed out that then contributes to burnout. These are the on the fly, in the moment, courageous discussions we have to have as part of our culture. And now I'm getting
and I agree. And when I go out and do education with the wearable staff dress badges, I say, put that on your shift huddle report. Did anybody activate their badge last night? And if the answer is yes, did you have time to report it? Because that's another system, right? That you have to kind of sit down, open up the incident reporting system. And that's the biggest barrier to reporting. You know it happened, but you just didn't have the time to do it. The charge nurse or the person of the day says, I got it. Give me the facts and figures. I'll enter it for you. So that way you're not reporting. Because if you don't report it, in your manager's eyes, you had a swift night, nothing happened, everything was great, and they have no knowledge of what happened. So AM huddle, PM huddle is a wonderful place for short snippets of exchange of information that can set the course of your day in the right direction.
100%. And I want to say this too. It is okay sometimes not to be okay, but we have to talk about these things. So I did a Reignite, Inspire, Support, Empower lecture out in Indiana about a month and a half ago. And one courageous nurse leader said, and I'm not going to directly quote her, but she said, there is a stigma with, if you speak up about workplace violence, you're soft or you're weak. Mm-hmm. If you say that you're burned out, you're soft or you're weak. We have to break down those barriers. We have to be able to say, I need help.
Absolutely.
I need help.
Because we know in the nursing literature that we laugh together and we cry alone. And that's not supportive. We need to be as supportive to anyone who's just as sad as they are happy, especially if it's because of, work issues. Certainly, I'm not asking you to come to work and cry because, you've got 1,000 things going on in your personal life. But at work, if something is making you sad, know that people will go and cry alone. they will not cry in public. And so we're always happy to laugh and tell, funny things about each other and work things. I mean, I think humor is sometimes, appropriate. But just remember, those same people that are laughing together often cry alone. And we need to be as accepting of that.
I love that. And one last thing, Jeanne, will you come back? Would love to have you come back.
Third shift. Yes.
And I just think we need to continue to have these conversations. I respect you, love you as a great friend and colleague, and really admire all of your knowledge in the workplace violence space. So this is an official request, an invitation to come back.
And we're going to be together in New Orleans at the emergency nursing venue, where there'll be 4,000 emergency nurses who live this, right? So let's keep our ears open for some solutions. So not always just talk about problems. Let's come back with maybe some ground level solutions we hear, and we can share their lived experiences with your group.
I love it. Again, Jeanne, thanks for all that you do.
It was my pleasure. Thanks for having me back.
I just always say this to the shifties. Remember, your shift makes a difference. Keep shifting. Enjoying the shift? Help us reach more nurse leaders by rating and reviewing us on your podcast app. It takes just a minute, but makes a big impact. Search for The Shift, tap those stars, and share what you love. Your feedback shapes our future episodes and helps others discover us. Remember, rate, review, and amplify The Shift today.